Good evening, respected seniors and friends. I welcome you all on today's COPD web series episode 2, that is on the basics of pharmacological management with a special reference to orals. First of all, I want to thank CCI for wonderful academic march for last many years, especially Dr. N.S. Krishna sir, Dr. Narayan Pradeep, our trustees of CCI. I also want to thank our CCI President, Dr. Ashish Dubey, and General Secretary, Dr. Anil Maske. A special thankful to Dr. Vijay Kumar Chennam Chetty, sir, Dr. Ravi Doshi, and Dr. Atri Mupadhyay for continuous efforts and dedication for scientific event regularly. Today we have a galaxy of panelists. We have Dr. Kulbir Singh Chopra, sir. Kulbir, sir, is a consultant chest physician and additional superintendent, District Hospital, Paota, and Allied Hospital, Dr. S.N. Medical College, Jodhpur. Sir, welcome. We welcome you all. Welcome you. We also have Dr. Kripesh Ranjan Sarmah. He is a consultant pulmonologist and head of department, Apollo Hospital, Guwahati. We also have Dr. Shyam Krishnan. He is a consultant pulmonologist, CK Birla CMRI Hospital, Kolkata. We also have dynamic Dr. Supreet Batra. He is senior consultant pulmonologist from Madras Medical Mission Hospital, Chennai. We welcome you all. Now I request without any delay, I request Dr. Shyam Krishnan to start his presentation. Dr. Shyam Krishnan, please. Over to you.
A very good evening to all of you. I'm Dr. Shyam Krishnan. I work as a consultant pulmonologist at CK Birla Hospitals, Kolkata. At the outset, I would like to thank the CCI Scientific Committee for giving me an opportunity to speak to all of you this evening. I would like to thank the audience present here for taking their time out after a tiring day's work and listening to this and participating in this particular event. So the topic for today is Beyond Inhalers, the role of oral medications in COPD management. It's a very interesting topic, and over the next 20 to 25 minutes, I would be giving you a brief overview of the oral medications which we use in COPD management, its pros and cons, the ideal patient selections, so on and so forth. And this would be followed by a panel discussion. We have an elite panel with a lot of expertise, and they would be discussing and addressing the common concerns and the questions you all have while managing patients with COPD and the place of oral medications as an adjunct to inhalers. So without much ado, I would delve into the topic and hopefully you get to utilize the expertise of the panel once the discussion starts. Thank you. So coming on to the topic, let me start the presentation. Yep. So beyond inhalers, the role of oral medication in COPD. We know that the whole pharmaceutical industry is geared up towards reducing exacerbations in COPD. It's not just the pharmaceutical industry; it's us as physicians and the governments, countries. Globally, it is a significant concern. Globally, because every exacerbation poses a significant financial burden not only on the economy of the country but also to the family. So hence, though inhalers are the mainstay of therapy, we also add oral medications when we feel that inhalers are not doing enough or we need to improve the patient's clinical status. So we would be doing a brief overview of the oral medications which are available today. Our focus would be on the theophylline and similar class of drugs like acebrophylline. We would be talking about N-acetylcysteine, oral steroids, antibiotics, and other oral bronchodilators. And we would evaluate each drug based on its mechanism of action, the evidence available, its utility, patient selections, and what are the do's and don'ts. So let's start with the first drug. So I kept acebrophylline at the top of the list. Basically, acebrophylline is a combination of two molecules, that is ambroxol and theophylline 7-acetic acid. Theophylline 7-acetic acid is a phosphodiesterase inhibitor which increases the cyclic AMP concentration within the smooth muscle cells, hence causing bronchodilation. The ambroxol component has a mucolytic action. It is also a surfactant stimulant. It thins the mucus and hence improves its clearance. The combination of both causes inhibition of inflammatory mediators, thus reducing airway inflammation. And there are enough evidence, though the quality of evidence may vary, which suggests benefits in reducing exacerbation frequency and improving respiratory symptoms in patients with COPD. This drug's basic utility is as an add-on therapy, particularly where mucus hypersecretion is prominent. So the patient subset I would use this particular drug is COPD patients with the chronic bronchitis phenotype, along with those who are frequent exacerbators. So the second drug, which is similar to this, is doxycycline. The mechanism of action of doxycycline is that it is a beta-2 adenoreceptor agonist, and it also has a weak phosphodiesterase 2A1 inhibition action. It similar to acebrophylline, it increases the concentration of cyclic AMP within the smooth muscle cells, causing smooth muscle relaxation and bronchodilation. It also reduces the inflammation by reducing leukocyte migration and reduces the plasminogen activating factor induced inflammation. It has clinical benefits in COPD. There are meta-analysis which shows that there is a significant increase in FEV1 compared to baseline, which enhances the airflow. It reduces the number of exacerbations, especially severe exacerbation rates in neutrophilic and the eosinophilic COPD subtypes, as observed in the studies over 3 to 6 months. It has also shown to reduce the glucocorticoid use in patients who end up with an exacerbation. It is a safe alternative to theophylline, and the key differences from theophylline is that it has no adenosine receptor antagonism, because of which the cardiac and the CNS side effects are minimized. It has no calcium channel interface, because of which it does not affect the calcium influx, thus reducing the arrhythmia risk. It is typically administered orally at around 400 to 800 milligrams per day. The next in line is N-acetylcysteine, probably the most prescribed drug in patients with COPD, apart from the inhalers, that is. Its basic action is of that of a mucolytic. It breaks the disulfide bonds in mucus and thus reducing the rheolytic property of the mucus. It also functions as an antioxidant. It replenishes glutathione, it scavenges the reactive oxidant species and reduces oxidative stress. It has an anti-inflammatory role by decreasing the pro-inflammatory signaling pathways. And in COPD, because of these effects, like it reduces the mucus viscosity and improves its clearance, it lowers exacerbation frequencies and also has modest symptom improvement in patients with COPD. So those are the reasons why we prescribe N-acetylcysteine. And there are clinical studies and meta-analysis which shows that NAC at higher doses, that is over 1200 milligrams per day, reduces the frequency of acute exacerbations in COPD patients. And this effect is more pronounced in patients with moderate COPD and those with a history of exacerbations. And there are trials which report modest improvements in lung function and symptoms, but the primary benefit for which we use this drug is basically reducing exacerbation rates and helping patient expectorate sputum. This drug, again, I would reserve it for patients of COPD with the chronic bronchitis phenotype who produces copious amounts of sputum, or those who have difficulty in clearing the sputum, and if it is especially thick. The next drug which we would be interested in is roflumilast. The roflumilast is a selective PDE4 inhibitor. This also increases the cyclic AMP concentrations in the smooth muscle cells, which also causes bronchodilation, and along with that, it reduces the inflammatory mediator release by reducing the neutrophil, eosinophil, macrophage and T cell activity. It reduces oxidative stress and also prevents airway remodeling. So thus, it reduces mucus secretion, improves ciliary function, inhibits pulmonary vascular remodeling. So that is why it is basically indicated in patients with severe to very severe COPD patients with severe airflow limitation, less than 50% of FEV1 predicted. We also use it in the chronic bronchitis phenotype and patients who have a history of exacerbations despite optimal bronchodilator therapy. There are studies which shows that it reduces moderate to severe COPD exacerbations by approximately 15 to 18%. And this benefit is greater in patients with the chronic bronchitis and the chronic bronchitis phenotype. So it is used as an adjunct with LABAs and LAMAs and ICS to improve symptom control and reduce exacerbation risks. Coming on to macrolides. So you see macrolides, how they act is, so if you see an exacerbation, an infective exacerbation of COPD, you have bacterial and viral infections which causes activation of neutrophils, and neutrophils release neutrophil elastase, and the infection causes airway inflammation, epithelial injury, it causes impaired mucociliary clearance, it causes mucosal edema, mucus secretion, smooth muscle contraction, and in the parenchyma it causes inflammation and injury, and this combined effect of all this results in an exacerbation. And the macrolides, how they prevent an exacerbation is that at each step it acts on different steps. So if you see in the activation of neutrophil stage, the macrolides inhibits neutrophil chemotaxis and survival, and thus prevents the activation of neutrophils and reducing the elastase levels. It also modulates the pro-inflammatory cytokine secretions, reducing the level of IL-8 and LTB4, so reducing inflammation. And it also has antibacterial effects, and which is because of the inhibition of the virulence factor production, cytokine production. It reduces Pseudomonas adhesion, it reduces biofilm formation by Pseudomonas. The bacterial quorum sensing mechanisms are disrupted by the macrolides. It also has little antiviral effects, and it also modulates mucus secretions. So because of all this, it helps in preventing exacerbations, and there is a clear benefit in moderate to severe exacerbations with signs of bacterial infections, that is increased sputum purulence, color, volume, and dyspnea. Prophylactic use of low dose azithromycin reduces exacerbation rates in selected frequent exacerbators, and this benefit is especially seen in smokers or former smokers. I'd forgotten to mention theophylline at the onset. So just getting back to the role of theophylline in COPD management. So this is one of the oldest oral bronchodilators which was used, but it did not gain popularity because of the cardiac and the CNS side effects which it had. So theophylline is a PDE inhibitor, phosphodiesterase inhibitor. It reduces inflammation and it also causes bronchodilation. So there is clinical evidence which suggests a modest bronchodilator effect compared to placebo. There are trials which shows that combination with salmeterol yields greater improvement in FEV1 and breathlessness than salmeterol alone. There is contradictory evidence regarding exacerbation prevention with low-dose theophylline. There is no significant benefit in adding low-dose theophylline to inhaled corticosteroids for reducing exacerbations. And there's a large trial which showed no benefit of oral theophylline alone or with prednisolone in severe COPD exacerbations. So its role in COPD management is not without risks, and there are better options available now in the market. And the side effects at near toxic doses which were observed were basically atrial and ventricular arrhythmias, which were potentially fatal. We also noticed that theophylline had incidences of grand mal seizures, and these seizures could occur irrespective of epilepsy history. And it had significant drug interactions, especially with erythromycin, ciprofloxacin, but not with azithromycin or ofloxacin. and it also had interactions with allopurinol and cimetidine. Coming on to the next oral medications which is commonly used is oral steroids. So we all know that this is our go-to drug, especially if there is an exacerbation of COPD, because this is one of the most potent oral medications with guaranteed effects mostly, especially when used in short term. So there is strong evidence for this for oral corticosteroids for its effectiveness in managing acute exacerbations. But there is limited evidence and there are significant risks associated with long-term use, especially in stable COPD. So the use is just limited to exacerbations. Long-term use we wouldn't advise because there is enough and more evidence which suggests that the risks of side effects are far greater than the benefits you would achieve in patients with stable COPD if you use it long-term. So the patient subset which you would consider is basically patients experiencing an acute COPD exacerbation. We use short courses for exacerbations and we need to assess the risk benefit carefully, monitor for side effects when you use them, hyperglycemia, mood changes, the risk of infections are more. Avoid long-term maintenance therapy due to severe side effects like osteoporosis, diabetes, cataracts, muscle weakness, immunosuppression. And obviously, we all know that we need to avoid abrupt cessation after prolonged use. So hence tapering of this steroids is needed. Now coming on to the last part is sorting out the myths from evidence. So there is always a dangerous myth that oral steroids are a safe option for long-term COPD control, but evidence clearly shows that the risk far outweighs the benefits. Thus, we need to limit its use only to acute exacerbations. And the other myth which is commonly followed is that, which patients also believe, is that, viewing NAC as a cure-all for exacerbations. In reality, its effect is modest and it's likely confined to specific patient groups, and it is just a mucolytic. It does not have, it's a mucolytic and helps reduce exacerbations, but that's it. And it is also incorrect to think that oral bronchodilators are equivalent to their inhaled versions. They generally are not. And finally, not every exacerbation warrants antibiotics. You need to differentiate between an infective exacerbation and a non-infective exacerbation. You need to rule out comorbidities. You need to rule out cardiac events which can mimic like a COPD exacerbation. So antibiotics, we should reserve them for likely bacterial infections. And their use should be guided by specific indications like increase in the mucus burden, volume, signs of infection, having fever, history of exacerbations, and response to existing therapy and accessibility factors. So the take-home message and the key learnings which I would want to reiterate to all of you is that oral medications serve as an adjunct to inhaled therapy in COPD exacerbation control and COPD management. Clinical evidence underscores the use of oral medications while encouraging a nuanced approach to treatment, considering both efficacy and potential risks. So that would be the end of the talk, and I would be happy to take questions. And but we have an elaborate panel. I think so. Most of your questions and most of the questions would be answered, would be taken care of by the panel. So I think so we can proceed for the panel discussion. Thank you.
Thank you, Dr. Shyam Krishnan. It was excellent presentation from oldest oral theophylline to newer ones like roflumilast. Excellent cover-up, excellent summarization from all the maximum oral medication. Shyam Krishnan has some technical issues, so I think he's unable to join currently. As soon as he joins, we will start the questions from Dr. Shyam Krishnan. First of all, I want to ask from Dr. Kulbir Singh Chopra, sir. Sir, what are the benefits and limitations of oral bronchodilators as compared to the inhaled bronchodilators? Kulbir Singh, sir, give some insight.
First of all, I should thank scientific committee for giving me this opportunity. As we are discussing that this is in the poor resource setup, where we should consider the patients who are from poor background. The benefits of oral bronchodilators are many. They are cheap, easy to convenient to use, and they can be used for a long period. Over a long period, they can be used.
Okay.
So, other is by using this oral drugs, you can decrease the dose of the inhalation therapy, the cost of inhalation therapy. Suppose we use acibrophylline in a COPD patient, then you can decrease the dose of the long-acting LABAs and this long-acting LAMAs, muscarinic. So, so the idea is to decrease the cost of the treatment and also the effectiveness of the treatment by using this oral medication.
And poor resource setting.
As the topic suggests, is the poor resource setting. In the poor resource setup, these oral drugs, bronchodilators, they play a very great role. Especially, I want to discuss the acibrophylline. You see, acibrophylline as a drug, it increases the surfactant production. By increasing the surfactant production, it decreases the viscosity of the mucus, and by decreasing the viscosity of the mucus, it increases the bronchociliary
clearance.
So, by that way, the bacterial infections, they are also cleared. When the bronchociliary clearance is good, and then the infections are also cleared, the bacteria are also cleared. So in this way, acibrophylline plays a very great role as a oral drug.
Okay, sir. Now my second question with Dr. Kripesh Ranjan, sir. Sir, how do oral bronchodilators work, and what are their mechanisms of action? Mr. Kripesh Ranjan.
Yeah. So we have different groups of oral bronchodilator available for treating COPD patients. So already our speaker has explained. So basically we have mostly theophylline and its derivatives are available. That is your theophylline. Then we have a doxophylline. Then we have aminophylline. Also we have another oral bronchodilator that is also available in India, is a salbutamol also. So salbutamol basically act through beta receptor. This will activate your beta receptor activate adenyl cyclase, and then that will convert ATP to cyclic AMP. Then other theophylline derivatives, they have more or less the same mechanism of action. Most of them usually work through this phosphodiesterase inhibitor, and that actually prevent degradation of cyclic AMP, and ultimately they lead to bronchodilation. Then apart from this bronchodilator effect, other theophylline derivatives like theophylline also they reduces the migration of anti-inflammatory cell like neutrophils etc. to the lungs, and also they seems to be reduce your pro-inflammatory markers also. So through this different bronchodilators works and they exert different level of bronchodilation in COPD patient.
Okay, thank you. Very well explained. My next question with Dr. Supreet Batra, sir. What are the most common side effects of oral bronchodilators, and how can they be managed?
So, starting with we have already mentioned the speakers and the previous panelists that we have oral bronchodilators, salbutamol, beta-2 agonists. So they cause usually beta-2 receptors, they cause tremor, they cause tachycardia, sometimes they can arrhythmias. They also cause muscle cramps and also hypokalemia. So all these beta-2 side effects can be decreased. Usually they decrease over the time because of development of tachyphylaxis. So, and we should make aware that this will settle down. In case of theophyllins and all, we need to monitor the theophylline level. That's why they have a very narrow therapeutic index, and we need to keep theophylline levels between 10 to 15 milligrams per ml, and very difficult to monitor in our country. So theophylline, that's why they have a higher toxicity. It's very difficult to manage and measure the levels. As compared to theophylline, acebrophylline and doxyphylline has got very less side effects because they do not have penetration into the brain, and also the cardiac side effects are very minimal with doxyphylline and acebrophylline. So these side effects can be managed by monitoring the patient and making aware of them, and if required, we can reduce the dose, or sometimes we need to stop these medications.
Yeah. Very well said. Very well said. My next question with Dr. Kripesh Ranjan sir. In what situation would you recommend oral bronchodilators or inhaled bronchodilators?
Actually, in practically and as per the guideline, also inhaled bronchodilators are always preferred, and there is no definite indication that where we can give oral bronchodilator over inhaled bronchodilator. But there are situations where we can use oral bronchodilator as an add-on therapy to the inhaled medication. So any oral bronchodilator in COPD is basically an add-on therapy, not a primary therapy.
Yes, very well said. Now I want to ask Dr. Kulbir Singh sir. Sir, how do oral bronchodilators fit into the treatment plan for patients with chronic obstructive pulmonary disease or asthma?
Chronic COPD patients usually take inhalers over a long period of time. And when there is in poor resource setup, we have to think about the cost also. Then the role of here comes acebrophylline and salbutamol. You see, when we give tablet salbutamol, it acts within 3 minutes. Onset of action is within 3 minutes, and over duration of action is 4 to 6 hours. So what salbutamol does is it causes it acts on the beta 2 agonist. So it acts on this receptor on the smooth muscle cells where it causes the relaxation. So not only it's acts on the bronchodilation, but it has some other roles also. The beta 2 receptors present on the endothelium on the ciliated surface. There the salbutamol acts and it causes the increased ciliary action. So ciliary clearance is also increased when we give tablet salbutamol. And other is it acts on also the glands where on mucous glands where the beta 2 receptors are present, and there this drug act and cause increase secretions from these glands. So in this way, salbutamol acts. It plays a very good role in the management of COPD, and also acebrophylline. When we give acebrophylline, this drug consists of 2 drugs, ambroxolol and
theophylline derivative.
The other is theophylline 7-acetic acid. So these 2 components makes this drug. So this drug causes increased surfactant production. Because of the increased surfactant production, the mucus viscosity is decreased. Because when the viscosity is decreased, the mucociliary clearance is also increased. So thereby causing this also the bacterial infections, they are also cleared. So acebrophylline plays a multiple role in the management of such chronic COPD patients. So these 2 drugs, oral bronchodilator, salbutamol and acebrophylline, play much big role over a chronic period, over a long period of time. So in such patient who cannot afford these inhalers, then in such patients, these 2 drugs, they help a lot.
Okay. Thank you, sir. Thank you. My next question is Dr. Shyam Krishnan. any specific comorbidities we all should take care before prescribing oral bronchodilators?
Sure. Thank you for the question, Dr. Ashutosh. So there are a couple of, when you anticipate side effects, so definitely comorbidities related to that particular organ. So for example, you'll have cardiovascular side effects. So you should see if the patient already has any cardiovascular comorbidity, and that can actually predispose him to any, kind of side effects. So especially, so if theophylline have, arrhythmias as one of their side effects, you should see if the patient has a history of any kind of arrhythmias, ventricular or atrial. For example, AF.
Okay.
Some history of a torsades the points or something like
Okay.
Drugs are usually excreted by the liver, metabolized by the liver. So any kind of hepatic comorbidities, hepatic dysfunction, and any neuropsychiatric issues in the past, so it can precipitate that. Oral azithromycin. So if you
slightly delay
can cause QT prolongation, ototoxicity, psychiatric CNS side effects, history of seizure disorders, hepatic issues. These are the ballpoints of more or less the comorbidity to keep in mind.
Very rightly said. My next question with Dr. Supreet Batra, sir. How do oral bronchodilators impact adherence, patient adherence, and quality of life? Is there any change with the adherence after adding oral?
Why patients are, even it has been seen in studies that most of the oral bronchodilators are prescribed by non-chest specialists like ENT, family medicine, and the physicians, primary physicians. And why they are prescribed? Because it does not require any monitoring, do not require any clinical test, PFT and pulmonary function testing. They are less expensive. And also the patient does not need any skills, and you need not educate the patient about giving the inhalers and all. So this is the most common reason the physician induced. Then coming to patient adherence, depends on several factors like social factors, patient-related factors, and disease-related factors. If patient has severe disease, comorbidities and all, they are likely to take the medicine, but adherence again for the short period or until they get relief. And the poor adherence leads to exacerbation, poor symptom control, and increases the exacerbation, and also increases the mortality, and also increased utilization of health resources. So all these are, I think it's related to all the environmental, social factors, patient-related factors, and also the disease-related, how disease severity. If they have a less severe disease, they are bound to poor adherent only, and if they are educated only enough that they have a problem, you need to take medicine, then only the patients will take. Otherwise, they are bound to make mistakes, and the poor adherence leads to poor symptom control and exacerbations.
Thank you. My next question is Dr. Shyam Krishnan. What are the challenges and benefits of using oral bronchodilators in specific patient populations, such as elderly or children?
So for children, the main issue is, since there are very few trials done on children, so finding the right dose according to the body weight, finding the right, indication when you would use them, that is always a challenge. And they're more prone to side effects, especially seizure disorders are more prone in children who are susceptible to side effects of theophylline. For the elderly population, I always feel, adding more and more tablets to their list of, ever-growing list of medications, it adds to the pill burden. And same here also, you do have issues with psychiatric issues, depression, so on and so forth. So these are the challenges I feel are there in these specific patient populations with oral bronchodilators.
Thank you. Dr. Kripesh, Ranjan, how can healthcare provider educate patients about the proper use and potential side effects of oral bronchodilators? Like our office staff, our sisters, how can they educate?
Yeah, definitely. Educating your use of the medication is very important because since oral medication also have certain side effects, they should inform the patient that if they notice certain things, particularly if you use theophylline or drugs that can precipitate arrhythmia. So if the patient feel palpitation or other thing, they should immediately consult their physician or other thing. all these things they have to explain to the patient, and also that the doses that has been doctor prescribed, they should not overtake. Many time you can see some patient has a habit that I am having breathing difficulty, so doctor has prescribed me this number of tablet, I should take double of it so I may feel better. So these kind of precautions, they should ask the patient to take care of it, not to exceed the doses, and they find any symptom related to likely to be a side effect of the oral medication, they should immediately consult their concerned physician. These are the things that a healthcare provider can help in keeping aware the patient about regarding the use of oral bronchodilators particularly.
Very well said. It has to be clearly mentioned that dose should not be exceeded by the
I have
pharmacy
seen
counter.
experience of some patients, they have found that they're taking some oral bronchodilator, they haven't relieved, then they took a double the doses.
Yes,
So
it's very common practice.
Tachycardia, yes.
Yes. Next question with Dr. Kulbir Singh, sir. Sir, what are the emerging trends and developments of in oral bronchodilator therapy? Any newer changes, newer directions?
When we see in poor resource setup, usually earlier we used to give tablet salbutamol or syrup salbutamol antibiotics. But over the period of time, the role of xanthines, particularly aciprophyllin, is came to known to us. And aciprophyllin plays multiple roles in various steps. It, as I earlier said, it increases the surfactant production.
Yes,
yes. It increases the it decreases the phosphate. It acts on phosphatidylcholine and acts towards the surfactant production and stops the leukotriene production. The leukotrienes production is stopped, thereby the inflammation, and so it also acts as an anti-inflammatory. So it is a mucoregulatory, anti-inflammatory. So also because of this, it acts on the mucociliary accelerator by facilitating the process. It decreases infection also. So just like metformin in diabetes, and just like metformin drug, which has a multiple role in various systems, aciprophyllin is also having various role and in multiple areas. So I must say that we should use aciprophyllin. So we are using aciprophyllin in asthmatic patient also now, and in COPD patients. So in both these setups, and also in poor resource setup, we are seeing the role of aciprophyllin, and patient is also comfortable with it. Earlier they used to take theophylline. Theophylline, it has a lot of issues, toxicity related issues were there. But with aciprophyllin, the patient acceptability is very good. They demand for it when they come after 1 month or after 15 days. If they specifically ask for this drug, aciprophyllin. Over the period, sometimes when we give this drug, we have to, there is symptoms are there. We have to sometimes add the steroids, short course of steroid also. But what I have said, what I have personally seen in the OPD, that aciprophyllin among all drugs, among all oral bronchodilators. The topic of today is oral bronchodilators. So basically, oral bronchodilators are salbutamol and xanthine, particularly aciprophyllin. And among these two, aciprophyllin is a very good drug. And
according to your opinion, aciprophyllin is the most promising oral bronchodilator.
And it will
can be tried in future
over
also.
The period of time, we will be knowing some other and many more actions of aciprophyllin, just like metformin in medicine.
Thank you, sir.
Thank you.
Dr. Supreet Batra, how might oral bronchodilators be used in combination with other medications or therapies to improve patient outcome or adherence?
Yeah. So we must realize that for all the diseases we are discussing, asthma, COPD, inhaled bronchodilators, inhaled medicines are the drug of choice. That are irreplaceable and cannot be replaced. Only thing is we have oral bronchodilator as an indication in those patients who are not willing to take some social stigma, or maybe there are cost reasons, or some. So in that cases, we can use oral bronchodilator and start people on therapy. Add on, and we must realize the standard indications for oral bronchodilator as an add-on therapy. It's not a first-line therapy; it's only an add-on therapy. And we have certain phenotypes like severe to very severe COPD, chronic bronchitis phenotype, and those who have FEV1 less than 50%, and also those who are frequent exacerbators. So these are the three categories of patient where we must use them as an add-on therapy, not as a first-line therapy. And in the patients who are not willing to start, they may, in those patients, we can be started as a start initial therapy, but patient should be convinced always for the inhaled bronchodilators as far as possible.
Yes, thank you. Well taken. Dr. Shyam Krishnan, what are the potential areas of future research and development in oral bronchodilators?
So I feel if you can develop a molecule which is, takes the advantages of the existing molecules minus their side effects.
Yes.
So developing, some theophylline molecules, a newer anti-inflammatory molecule, basically, which can, achieve the same kind of efficacy as the existing ones, or if not better, but without the side effects, without the CNS side effects or the cardiovascular side effects. That would be one area to, explore. The other one would be better mucus regulators. They're trying different. So in the area of interventional pulmonology, they're trying different therapies like cryotherapies, cryosprays, especially just to modulate the mucus secretions in chronic bronchitis patients. So if you have drugs which can do that, that would be good. The third would be personalized medicine. If you have some kind of, if you can target certain genetic, defects, which are probably related to, mucus hypersecretion or something, and then give targeted medications for that. Like in ILD, they targeted the MUC5B gene with N-acetylcysteine. So similarly, if you have something, on those lines where you can have personalized targeted therapies to patients, that would be one area to explore.
Yes, thank you. Dr. Kripesh, Ranjan, how do different oral bronchodilators compare in terms of efficacy, safety, and patient outcome? For example, theophylline, acebrophylline, and doxorubicin.
Yeah, definitely. I was going through one of the study where they have compared all these three drugs in terms of efficacy and side effect in COPD patient. So in that trial, they have found that if you see bronchodilator action, this is maximum, this efficacy wise, the doxorubicin is more effective compared to theophylline and acebrophylline. And if you see the mucolytic property, if you see that is more in favor of acebrophylline. And if you see the side effect profile, then it is more side effect with the theophylline. So comparing all the three molecules, doxorubicin is well tolerated and is more better. Then this is followed by acebrophylline. It is a more anti-inflammatory but a very weak bronchodilator, and the theophylline comes last because of it has a lots of side effects, and again it's needed therapeutic drug monitoring also.
Okay, thank you. My next question with Dr. Kulbir Singh sir. How do oral bronchodilators compare to other treatment options such as inhaled corticosteroid or combination therapy?
Pardon, please repeat the question.
Yes, sir. How do oral bronchodilators compare to other treatment options such as inhaled corticosteroid or combination therapy?
What I have to tell compared
yes,
to
yes. Inhaled corticosteroid.
What are their side effects?
Yes, yes. Is there any benefit to add on with inhaled corticosteroid or oral bronchodilator therapy? Inhaled bronchodilator therapy. Is there add-on effects on bronchodilator?
Yeah.
Oral.
Yes.
After adding oral bronchodilator on inhaled corticosteroid.
If a patient is on inhalers,
corticosteroid, yes, inhalers, yes.
If we
combination therapy.
Sometimes
ICS-LABA combination. Is there any add-on benefit for adding these?
Yes. If a patient is on the inhalers, long-acting muscarinic, LAMA, or long-acting beta-2 agonist, sometimes the symptoms are not relieved fully. Okay. Then in such setups, if we add the tablet acebrophylline, the response is good and the patient acceptability is also good. And apart from all the multiple action of the acetylprophylline, they take place and patient is relieved from the discomfort he is feeling earlier. So you see, when we add oral xanthine like acetylprophylline, doxycycline, and other xanthines, when compare on the patient who is already on the inhalers. So this oral drugs, they decrease the need for the inhalers. So the inhaler dose, it can be reduced. Otherwise, the patients are going on taking the Oracort, formoterol, budesonide combination. They are taking it. They don't get all the relief that's needed. Then we have to add this oral bronchodilators like acetylprophylline. Then the patient gets better relief compared to the earlier situation. So there is a great role for oral bronchodilators in such patients who are taking inhalers over a long period of time. Sometimes they take inhalers and there is a problem of fungal infection, sore throat. So in that cases also these oral bronchodilators have a role to play.
So you want to say that inhaled corticosteroid dose can be reduced after adding oral bronchodilator.
Cost can be reduced, dose can be reduced in both way. So these oral bronchodilators, they play a great role over a long period of time. In poor, as the topic suggests, it is a poor resource setup. In poor resource setup, what happens? You write inhalers. They are costly. Initially, the patient takes it. Then over 1.5 months after that period, he defaults. Okay. So when we add this oral bronchodilator, there is chances of coming to you and patient to the doctor is more and is getting relief also. So by adding oral bronchodilator to the patient who is already on inhalers, we ensure that he will stay with the treatment plan and he will not default.
Thank you, sir. Now, next question with Dr. Supreet Batra. Any update on role of statins or leukotriene modifiers, especially in COPD?
Yeah, there were few trials in which simvastatin were tried at a doses of around 20 to 40 milligrams per day, but none of the trials showed that the statins or leukotriene receptor inhibitors decrease the exacerbation in patients with COPD if given without an indication. But it has been found in some observational studies that if statins are given for any cardiovascular or a metabolic indication like hyperlipidemia and all, so they are found to have that they might have some role in preventing exacerbation. But as per those were all observational studies, none of them were randomized controlled trials. So as of now, there is no solid evidence to suggest that statins or leukotriene receptor inhibitors prevent the exacerbation in patients with COPD.
Okay, thank you. My next question is Dr. Shyam Krishnan. A role of biological therapy, for example, benralizumab in COPD.
So biologics, benralizumab, there were two large trials. I think so, the Galathian and the Terra Nova trials. They did not actually meet the primary outcomes of reducing exacerbation rates. But dupilumab, on the other hand, has been included in guidelines where you can use it for reducing exacerbation rates. But it still is towards patients, in the niche group of patients where you have eosinophilic inflammation and they're prone to exacerbations despite maximal therapy. So that is the group we are there. And then if you have COPD along with, comorbidities like ABPA or some kind of eosinophilic syndromes, there it could work.
Frequent exacerbation.
Yes. Eosinophilic subtypes, despite maximal therapies and still having exacerbations, you could consider this.
Okay, thank you. Dr. Kripesh Ranjan, role of N-acetylcysteine and ardostin in COPD, and which one is better, N-acetylcysteine or ardostin?
Definitely. Okay, so both has almost anti-inflammatory properties and both have shown to reduce COPD exacerbation rate. But there are also head-on clinical trials comparing N-acetylcysteine, ardocysteine, and carbamazepine also. So in that trial, they have found that this and compared to N-acetylcysteine, ardocysteine is more effective and much better in comparing reducing exacerbation in COPD.
Okay. Thank you. Now I want to ask Dr. Supreet Batra, treatment options available for smoking cessation. What are the treatment options we have for especially smoking cessation?
For smoking cessation, we have nicotine replacement therapies. We have got two drugs called bupropion and varenicline. But the guidelines suggest that you must start with either the first line therapy can be a combination or nicotine therapy, because you need to have short-term effects and also long-term effects. So like you can combine a patch, nicotine patch with a nicotine gum or a lozenges. And again, there are some indications for that, like if patient wakes up early in the morning and starts smoking within 30 minutes, the dose is higher, like 4 milligrams for a tablet or a lozenges. And if the patient smoke more than 10 cigarettes per day, then the dose is around 21 milligram. And you start with, if less than 10, then it's 14 milligram. So combination replacement therapy is the first line therapy. And the other best drug is varenicline, which also you start and there's a dose of 0.5 milligram for first 3 days, then make it twice daily for next another 4 days, and then 1 milligram twice daily for next 12 weeks. So you have to give. This has also been supposed to be one of the best drugs. You can combine also nicotine with varenicline. That is a second line therapy. But the first line therapy, they always suggest is combination. And we have also got a drug called bupropion, which is, you have got a specific indication, like its dose is 150 milligrams. And that it is in a specific group of those who have a psychiatric background or a depression, and in those patients you can give, but it has a chances of exacerbating a seizure, has a side effect like can cause seizures. So that we must take care about the comorbidity or any patients must having this. So these are the group of drugs, but the still nicotine replacement therapy remains the number one drug of choice in a combination with a tablet or gum along with a patch.
Okay, thank you. Dr. Shyam Krishnan, nicotine replacement therapy, bupropion and varenicline. What are your preferences?
So, see, if you go evidence-wise, it is definitely varenicline wins hands down. So most meta-analysis say that varenicline as monotherapy has the longest period of abstinence compared to bupropion. And bupropion you can always use because it's easy to, it's 150, twice daily, or you can start with low dose and then go up to 2 times. But the thing is, like seizure disorders, that's the only contraindication in a way where bupropion doesn't work well. But in combination therapy, like Supreet had mentioned, varenicline with treatment therapy, that works the best.
Okay, thank you. Dr. Kulbir Singh sir, any role of long-term use of oral macrolide therapy in COPD?
Oral macrolides,
COPD.
long-term use in COPD, yes.
Sir.
It has a great role to play, especially in this setup. We see that macrolide antibiotics like azithromycin reduces the frequency and the severity of the exacerbations of the COPD. They exert their effect through the combination of mechanisms like anti-inflammatory, antiviral, immunomodulatory actions, as well as the antibacterial effects. But what we see is that there are side effects also over the long-term use of the macrolides. So we should also keep that in mind.
Okay.
So
thank you, sir.
Thank
you. Macrolide acts on multiple modalities. You want to say, sir?
Yes.
Thank you, sir. Dr. Kripesh Ranjan, role of phosphodiesterase inhibitor, especially roflumilast in COPD.
Yes, roflumilast also act through your phosphodiesterase. Specifically, it acts through phosphodiesterase 4, and it has also the same bronchodilator action. Plus, it has an anti-inflammatory property by reducing the inflammatory cell and the inflammatory mediators also. But again, there's a trial. They have shown that roflumilast is also an effective oral drugs compared to other. But the most problem with the roflumilast is it's a side effect. So it has a weight loss has been noted to up to 10% of the patient on roflumilast, and also 10% patient has a side effect of around have complaining nausea and other things. So because of its significant number of side effects compared to other oral bronchodilator or other oral molecules, it use has been seems to be limited and has been also not growing so much.
True. We are not regularly using roflumilast due to its side effects. Yes.
Yeah, exactly. I'm not using it for a long
Yes.
time.
I am also not using it for long term. Dr. Kulbir Singh sir, role of oral corticosteroid in the COPD.
Yeah, steroids play a significant role in COPD management. Particularly, they reduce inflammation and improvement of the lung function. In stable COPD, they reduce exacerbation rates. Inhaled corticosteroids, especially when combined with long-acting bronchodilator, can decrease the frequency of the COPD exacerbation. But here we have to be very careful because giving steroids to a patient, suppose it can increase the leukocyte counts, it can increase the blood sugar levels. So we should be very careful while giving steroids. But yes, they decrease the duration of stay in hospital and symptom relief are there. Lung functions is also improved, and FEV1 it also increases. But we have to be very careful while using steroids, especially what I have said, told about that the raised sugar level, and it can increase the leukocyte counts, leading to the even if we don't suppose I am giving some prednisolone to the patient who is on this stable COPD patient or is admitted in the ward. Even for 2-3 days, I have given him prednisolone 4-5 days, and I have not keep this thing in the mind that we have to withdraw also at the suitable time. So this thing happens. For it helps, but we have to be. It is double-edged sword, so we have to be very careful about when we use steroids.
We should use short-term only, sir. As you said, we should use only in exacerbation.
It decreases the
yes sir,
exacerbation rate. It improves the FEV1.
Sir, which one should be used? Prednisolone, Deftacart, or methylprednisolone? What is your preference?
You are saying now it is a poor resource setup.
Yes.
When it is poor resource setup, we go for a prednisolone, which is available.
Definitely, sir. Definitely, sir.
So we keep in that thing in mind. We should do that.
Dr. Supreet Batra, sir. Some studies uses oral moxifloxacin and oral doxycycline also. Had it any long-term role in chronic bronchitis variant?
Yeah, so there were few studies. One of them, the rationale for giving the moxifloxacin was same like azithromycin. So what is the cause for exacerbation is the back inflammation. So the rationale was by giving an moxifloxacin 400 milligram for 5 days every 8 weeks, every 2 months, will clear the bacteria from the lower areas of the COPD patients, and which will reduce the inflammation and prevent an exacerbation. But the studies which were done did not show any significant benefit or reduction in exacerbation in both the placebo and the moxifloxacin arm. Also, there was an acquired organisms. New organisms were also grown up, which resulted in exacerbation. So that was moxifloxacin. That study was not did not show any decrease in exacerbation. Again, doxycycline, as Dr. Shyam has showed us one slide, that elastase and metoproteinase. So doxycycline, one of the side effects is immunomodulatory effect, apart from antibiotic effect. So it inhibits matrix metalloproteinase enzyme, so which is released by the neutrophils or inflammation and causes destruction. So by doing that, they were thought that by giving doxycycline 100 milligram, we can reduce the exacerbation during the inflammation. But those studies were also failed to show any significant or reduction in exacerbation. But there was a subgroup analysis in which they found that those patients who had very severe COPD or eosinophils less than 300, in that subset of patients, doxycycline reduced the exacerbation. And for moxifloxacin, again, there were those who were chronic bronchitis phenotype, severe COPD. In that subset of patients, there was a statistical significant improvement. Otherwise, overall, the study was a negative trial, and there was no decrease in the risk of exacerbation in the moxifloxacin as well as the doxycycline arm.
Okay. Thank you. Any update on the other modalities despite from the we discussed? Then any role of chest physiotherapy or pulmonary rehabilitation and the COPD management despite those is different topic. Supreet, Batra.
Yeah, so pulmonary rehabilitation, we all know that it is one of the grade 1 recommendation in patient with COPD, and it should be started inside the hospital itself during the exacerbation within less than 4 weeks. It has been found to improve the patient compliance, also its symptom control, and also increases the quality of life. So that is an update on the exacerbation. There are bronchodilators which also help in improving the rehabilitation outcomes, like tiotropium is one of the drugs, antimuscarinic, which improves the muscle endurance and also increases the physiotherapy rehabilitation PR program. PR is usually given twice to thrice in a week for a 6 to 8 weeks program in a hospitalized setting. Nowadays it can also be given at home. That is called home PR, pulmonary rehabilitation. And nowadays there are digital platforms also through which pulmonary rehabilitation is given. Usually it is given, reduces a dynamic hyperinflation and helps in symptom control, and also patient increases his exercise capacity. You are mute, Dr. Ashutosh, you are mute.
Okay. Am I audible? Yes. Okay. Thank you. Some person asked from the audience that how long should we use oral bronchodilator? Should it be lifelong or we can stop in between? Any of panelists, please.
So I feel the same cycle which we need to go. You need to diagnose, assess, adjust. The same cycle. So whenever you call your patients for follow-up, I think so at least minimum 3 months should be the duration unless the patient has side effects. But I think so you can continue it for at least. So my practice is at least continue it for 6 months to a year. Okay. And then decide whether it's increasing the pill burden, whether he can do without it. If there are no history of exacerbations in the last 6 months to a year, I try to downgrade it to just I try to reduce the medications if the patient is exacerbation free. But if he has had an exacerbation in the last 1 year, despite these drugs, I still don't cut it down.
Okay, thank you. Is there any role of beta blockers in COPD? Dr. Shyam?
So yeah, so beta blockers. So there were a lot of trials which shows continuing beta blockers is actually beneficial, but it depends which beta blocker. It should be a cardioselective beta blocker, bisoprolol or carvedilol. Bisoprolol is quite is actually safe, and there've been there's an audit study. And there was one more study, which is a large, it was probably I don't know if it's a meta-analysis, but it's a randomized control trial where they found that patients, especially with cardiovascular comorbidities, and where they had stopped the beta blockers, thinking it would affect the COPD patients, and it actually worsened the mortality rates in them. So beta blockers do I feel, and evidence also, there is enough evidence to support cardioselective beta blockers. It's important to continue them.
Thank you. Any panelists want to add anything?
Beta blockers
summarizing
have a role. Beta blockers have a role in treatment of the COPD patient. You see, the beta 2 receptors are also present on the ciliated surfaces endothelium. When this drug act on them, these receptors, so it increases the ciliary escalator mechanism, okay, by which the mucus is secreted and the infection, the bacteria. So the bacteria does not add up to the wall, tracheal wall, or of the mucous surface. The bacteria adhesion to the mucous surface is decreased by the ciliary escalator mechanism when it's geared up. So the beta 2, this salbutamol, what we are saying, or other drugs like long acting formoterol, they have a role. So when we give these drugs, they act on the beta 2 receptors, thereby increasing the ciliary movement, thereby increasing the ciliary escalator mechanism, thereby the mucus is what we say that is emulsified and it's taken out from that area, and the bacteria adhesion to the mucous wall also decreases. So in that way, the this beta 2 these drugs are in that way helpful, like salbutamol in COPD patients.
Thank you. Thank you, sir. Any other panelists want to comment anything on oral bronchodilators which we have not covered?
I think last question was regarding beta blocker, not regarding the beta agonist.
Yes, it's beta blocker. Yes,
regarding the beta blocker, not the beta agonist.
Yes.
So what do I mean to say is, it's a myth that beta blockers can't be given in obstructive airway disease. Actually, they can be given. It is a cardioselective, but there's an indication for that. Like COPD patient with heart failure, COPD patient with having arrhythmias, atrial fibrillation. So cardioselective beta blockers actually help them in reducing the heart rate. So if you reduce the heart rate, the ventricular filling will be more, output will be increased. So they have a better outcome, better exercise capacity. So there's a specific indications for that, but it's not a no more a myth that beta blockers can't be given in obstructive airway disease.
That's very well said. Very well said. I think we should bind up our today's session. To summarize, I want to say that oral bronchodilators still have role, especially on poor resource setting, with add-on treatment with LABA-ICS combination, dealing with the potential side effect of the drug, and future therapies further come up to reduce the side effects and increase efficacy. Like newer drugs, oral biologicals, injectable biologicals can help, especially in the frequent exacerbation, as already said by our panelist, dupilumab, that is monoclonal antibody that blocks IL-4 as well as IL-13 receptor. And N-acetylcysteine, iodine also has a role. So we can summarize that there is always a role of oral bronchodilators, especially in the obstructive airway disease, in COPD, and chronic bronchitis variants. Thanks to all the respected panelists for sparing time and elaborate the discussion. Thank you, everyone, and thank you, CCI, and thank you all the delegates and all the faculties for joining today's CCI webinar part 2, that is on the pharmacotherapy, especially focus on the orals. Thank you, everyone, for joining.
Thank you, everyone.
Thank you, everyone.
Namaskar.